All right, so we're recording, and it's June 5th, so this is our first lecture for this unit, Unit 3, and really, this marks kind of the point in this semester where there's not going to be much of any new material, maybe a little bit, but we want to spend the rest of June and July more focused on review and incorporating board vitals into the kind of your preparation for the comp exam and for boards, very importantly. So that being said, we're good. We wanted to focus on kind of the interaction between medical and psychiatry, maybe a little more focused. This unit, some special populations who have some sort of medical condition that would be a primary concern, would greatly affect prescribing practices and dosing and those kinds of things, which is a good opportunity for us to revisit and encourage you to revisit some of your first year advanced patho and advanced assessment material, because ANCC is going to expect you to know all of those things, not just disorders and treatments specific to psychiatry, if that makes sense. So they may ask you a question that you need to know. You need to know what the troponin of 0.4 might mean, or things that that's not in our purview, but they're testing across kind of that basic knowledge. So we'll get to talk about medical conditions and kind of revisit labs and how, from a practice standpoint, pharmacology may need to be adjusted, personalized for someone. So we'll start with Andrew, young guy, feeling really depressed, 3-month history of those things. Anger, reduced energy, muscle tension. So anything kind of jump out. We don't have any polls today. We're just going to ask questions as we go. Super overview thoughts from anybody. Says he's depressed. Sure. Yeah. Getting lots of clinical hours. A patient comes in and says something. Your funnel begins, and you kind of start asking questions to narrow it down. Could be depressed. Certainly, you meet the time criteria. It's more than 2 months for sure. Indicates anhedonia, insomnia, trouble. We don't know if it's initial or terminal. Anger, does that mean irritability? Goes in at reduced energy, muscle tension. He's 24, so he's young enough that he could easily end up with depression. He could end up having bipolar disorder. He could potentially, age-wise, end up with some sort of thought disorder. Kind of anything. Sky's the limit, right? So let's get some more information on this guy. So 6 months ago, he reported that. Now this is, say you're seeing this guy with these complaints, you would be suspicious of a medical cause to this, and we always want to rule out substance and medical first anyway. So you send to the PCP out of suspicion. A rash on the tongue, not that we are epidemiologists or that we need to be, but from a, right, thrush, sure. There are some things, if you're working with folks and kind of the presentation just doesn't make sense, or that it is the weight loss issue, some other infectious, unrelated, unexplainable kinds of symptoms, don't hesitate to say, I want you to go get checked out by medical to be sure all your other pieces, parts are working okay. So he goes and, thrush in an adult would be very concerning because of the immunocompromise that you might suspect would be required to have that. And that fairly classic presentation. So CD4, and this is when you're looking through, I would think this is going to be in your there will be a section on infectious diseases in patho, but there may also be that in assessment because they're real big on primary prevention and secondary prevention whenever you can. And the standards would indicate, now starting to screen for infectious diseases as a standard kind of thing. We talked about screening for depression, making that a standard thing. That's in the Healthy People 2020, that more folks are getting screened for it. So yeah, and HIV, you will want to know in a related but distinct kind of concept the ages at which they recommend starting to screen for breast cancer. So mammograms, what's the age that should start? Pap smears, colonoscopies, PSA levels for the prostate issues, for prostate cancer. And those are standards set out by the American Academy, the obstetrics and gynecology people, the urology people. And I'm trying to think if that would have been covered in your patho or your assessment. I really want to say assessment. So again, as you're preparing for the ANCC exam, they like prevention, primary, secondary. So talking about these immunizations, kind of ages that they become appropriate, ages of screenings. I remember when I was studying for boards, they just drilled that because it's stuff that I sure didn't remember. I mean, I did not remember that. The labs as well. So in this case, CD4 in the context of HIV, and we included an HIV PowerPoint or PDF kind of fact sheet there, knowing what really all of your normal hematologic labs are going to be, like a normal hemoglobin hematocrit for women versus men. Normal CD4 count's going to be over 500. So 300 is indicative of an insult to that population. And also the fact that the person is hepatitis C virus positive. So not a surprise that this person, Andrew, has acquired two diseases that are communicable through body fluids, through sexual contact, unprotected sexual contact, IV drug use. But of course, this is to confirm. That's not something that we would do. This is an area where we refer to primary, and they would probably potentially refer to an infectious disease specialist to confirm the presence of the HIV virus. Because a CD4 count of 300 the person is immunocompromised, but you wouldn't say immunodeficient, so he wouldn't be diagnosed with AIDS at this point with the CD4 of that level. But being HIV positive, and potentially depressed, and also Dr. Fogger's practice is with patients at 1917 clinic, all of whom are being treated concurrently for an HIV infection, and folks who maybe wouldn't meet criteria for depression or for a trauma-related disorder before the diagnosis may end up developing symptoms of depression or panic. So, any thoughts that you have, Dr. Fogger, based on your experience of working with these folks?
Generally, statistics suggest that the folks who end up testing positive for HIV have a increased chance of developing a depression, and it's sort of a kind of a question about whether it's about the demoralization about having HIV and feeling like it was a lifelong disease process, and the other piece is that the HIV actually causes depression in some folks. So about 50% of the folks who have HIV have a depression during their lifetime. I would also say that oftentimes how an individual gets HIV may be also suggestive of the fact that somewhere in their past they may have had trauma, abuse. Of course, males having sex with males is without use of a condom is a major way that people end up developing HIV. But for women, it's about having sexual relationships with men who are swinging both ways. They are men that have sex with men and also have sex with women. So it puts the person at risk not using condoms for protection. And then other behaviors that just are risky behaviors, such as IV drug use and sharing needles and sharing sex for drugs, may also put people at risk. So anybody can get HIV. It is about coming in contact with somebody who's positive and not being treated, because once people get treated, their viral load decreases and they may become undetectable. When they're undetectable, they're not infectious, which is the reason why getting people into treatment is so important. So if you're dealing with anybody who's HIV positive, then I would just, part of the process is to ask them if they're taking their medicine, positive strokes for taking their medicine. Because unfortunately, with the HIV population, there are some folks who choose not to take their medicine. And unfortunately, their life expectancy by choosing not to take their medicine, usually the disease process runs its course relatively quickly. And unfortunately, they usually die of some secondary infection, such as pneumonia. But for folks who have had HIV for a long period of time, they're finding that other problems are coming up, such as cardiac. And with folks who have HIV, because pain is such a major part of it, because you'll have joint destruction, partially because of the HIV, that the pain component and depression, which goes hand in hand, may be part of how you get involved with patients, is because they've got chronic pain issues, chronic depression. So it's complicated, but it makes it really interesting when you're working with this population.
Yeah, 1917, I don't know if anyone in the rooms currently has had a chance to precept at 1917 clinic here in Birmingham, but it is certainly one of the research leaders, and has been for a long time, in the treatment and prevention of HIV and treatment of folks with HIV. And so just some things to consider. And you'll work with folks with HIV anywhere. It's okay. Tish has. HIV is not discriminating. It will set up shop pretty much anywhere. And so it's something worth, patients may not want to disclose this to you. You could work with somebody for a long time and you never knew, unless I guess it was on their chart for some reason. Or if you recognize they're on an antiretroviral therapy, and then you would know. So just to, like Dr. Fogel was saying, it may have some bearing on their, psychiatric day-to-day functioning, how they view themselves. Some people have said that they had nightmares after they were diagnosed, and then essentially residual trauma-related symptoms after the diagnosis. But certainly encouraging asking about sexual activity as part of the social history when you do an intake for anybody is probably a part that gets left out more than anything else, maybe because it doesn't contribute. Kind of sexual history doesn't necessarily contribute to your psychiatric diagnosis. It could tremendously.
It could. One way that it could contribute is just by asking how many partners have you had in the course of your lifetime, and that the more partners, the higher the risk would be. Mm-hmm. Some folks probably like the fact that they realize that the number of partners that they have is embarrassingly high, and they may choose to kind of tone that down a little bit. But there are some folks who've slept with as many as 500 people in their lifetime.
Yeah. I guess that makes me think too, is when we're doing a psychiatric interview or interview for psychiatric diagnostic treatment management purposes, that we still need to be screening for major health concerns that may not, substance use, sure, that could exacerbate, complicate treatment, but asking about sexual partners, sexual safe sex practices, substance use in particular, high risk substance use, we should be doing that too, just as generally as healthcare providers. So if that encourages anyone to include that or components of that in a regular assessment and regular screenings for people too, because folks' behavior will change. And then one of the main issues if you're working with someone on an antiretroviral treatment is that these tend to be pretty difficult to process on the kidneys and on the liver. So if you're working with someone and you're prescribing them medications, that maybe renal clearance is something you would watch more closely, or it's a drug that can be hepatotoxic. Maybe they're on naltrexone for some other reason. Maybe they're on Depakote. Buspar is exclusively renally cleared, so that's something you'd be concerned about. Your effects are things that can, lithium, of course. So just to consider the interaction that those drugs will have on systems that clear your drugs. And a lot of those medications as well, antiretrovirals, can be pretty potent inhibitors or inducers of other medications. So you'd want to know, okay, this raltegravir, this drug it inhibits 3A4, or it really inhibits 2D6. Let me check my drugs and see, are they metabolized by that pathway, and adjust or choose different. And Dr. Fogger had mentioned pain, joint destruction that comes from this. HIV it's a virus, and it's not supposed to be in your body. Your body recognizes it as such, which is going to incite an inflammatory response. So folks with HIV may have more generally an inflammatory response because of this resident infection, and HIV can hide in the brain, maintain its presence and initiating inflammatory processes. And the medicines retrovirals have a harder time getting into the brain, crossing that barrier. So your CNS becomes a reservoir for HIV infection. And we know that any kind of excitotoxicity inflammation in the brain is really detrimental for cognitive functioning. And then the pain, as Dr. Falgard mentioned. So things that you would monitor for, assess for, screen for, and then keep in mind the interaction with those medicines. The medicines that we might consider prescribing. Gordon is significantly older than our previous fellow. 72-year-old African-American male, 2-year history. Kind of staying home, weight loss, not as interested in eating, restricted affect, but may have a forward lean, a shuffling gait, he's unsteady, resting tremor. Would you suspect that he has depression? You would not. Right. Yeah, this is a case when kind of more early Parkinsonism there's some cognitive and emotional consequences of Parkinson's that may, in some cases, may precede the motor symptoms. So yes, you would want to consider in your differential that maybe it's not his first ever episode of depression at 72, to consider Parkinson's, especially if standard treatment, SSRI, sure, no effect. So potentially Parkinson's. Those of you who work with maybe an older population, you would keep this potential on the back burner. For folks, you wouldn't consider this for Andrew, for our first person. But someone in the late 60s, 70s, absolutely. And Parkinson's is caused by a deficiency of what neurotransmitter? Who is the culprit? It's a neurotransmitter who is responsible not only for... Okay, great. Thank you, Kelly. Thank you, Kelly. Dopamine. Right. Dopamine does a whole bunch of things. And one of its main functions is in motor control, inhibition, selection. So if it's a low dopamine thing, and this is when you pull back at substantia nigra, is where dopamine gets produced, and it's in the ventral tegmental area, and it projects all over the place into the brain, anywhere that dopamine is needed, frontal cortex, midbrain, motor system, basal ganglia is the big hub of fine-tuning movement, where your deliberate choice, frontal cortex, I want to move my arm. Motor cortex says, okay, let's move our arm. Well, it has to go through a kind of a labyrinth of pathways to say, in order for me to move my arm, I need to do this, but I need to not do all these other things. And that's dopamine's job, is to fine-tune enough of the go signal and enough of the don't go signal. It's one of the reasons why dopamine, insufficient dopamine in kids and adults with ADHD, why they have difficulty regulating their go versus don't go signal, inhibiting responses, staying focused, maintaining focus and attention on a task, and then not being focused and attentive to all these other tasks. So if low dopamine is the issue, and unfortunately with Parkinson's, it's progressive destruction of those neurons, so there's no reversing it. A lot like with Alzheimer's, it's a putting on the brakes and trying to slow the decline. So if we could just increase the amount of dopamine that's available floating around in the brain through that system to support continued do this, go signal, don't go signal, then that would be great. And these are drugs that, if you work with somebody who's real neuro heavy and they're comfortable managing Parkinson's symptoms for patients, you may get to where this is a regular part of your practice. Where I have worked, this is something that tends to be deferred to, interestingly enough, to primary care or neurology. But anyway, so if you want to boost dopamine, you have some options to it. There's a dopamine agonist. These drugs, they're not actually dopamine, your body thinks it is. It's a dopamine substitute. So if we can't necessarily increase the amount of dopamine produced in the body, maybe we can prevent the destruction of what is there. Similar concept to Aricept and some of the Alzheimer's medications prevent the breakdown of acetylcholine. And here, maybe we can prevent the breakdown of dopamine. And that's done through, essentially dopamine breakdown inhibitor, selegiline, or these capones down here. Monoamine oxidase B, if you want to grab that back from your memory, that is an enzyme that is more selective for breaking down dopamine. Catechol O-methyltransferase, COMT, is another enzyme responsible for deactivating dopamine. This is a third enzyme, this dopamine decarboxylase, that also breaks down, makes dopamine no longer dopamine. Dopamine's in a very long kind of metabolic chain of dopamine going to dopamine, norepinephrine, and serotonin are metabolized kind of in a sequence. So it may not be metabolized to an inert substance, but it's no longer dopamine. It can't act anymore. So the meds that are number one for Parkinson's these days are some combination of levodopa, which is just actually substituting dopamine. It can survive in the periphery. It can make it across the blood-brain barrier. Anytime you see levo, that just means left, and they're talking about an isomer of whatever the rest of the title is. So this is an isomer of dopamine, and its shape, its configuration is going to make it easier to pass through, usually blood-brain barrier. So say the person they're on these medications to provide dopamine, prevent its breakdown. What adverse effects would you expect potentially if you're suddenly going to boost dopamine beyond what was previously there? Sure. Yeah, dopamine, these aren't laser treatments where you're only gonna increase dopamine in the striatum or in the basal ganglia. It's gonna increase everywhere. And for some folks, an increase of dopamine on D2 receptors in particular may cause symptoms of psychosis, or maybe of hallucinations, or some persecutory delusions. A patient who's being treated for this with this Sinemet or one of these medications, they may be convinced that family's trying to poison them or is taking their things. Some delusional, you would be alert to the presence of some positive symptoms because And it doesn't mean they suddenly have schizophrenia. This could be a medication side effect. Nausea, vomiting, dopamine is one of the chemicals, one of the ways that your brain communicates a need to expel stomach contents. Nausea, vomiting. It's why dopamine antagonists are effective antiemetics. So specifically education you'd want to provide the patient. And again, when you boost dopamine, you may simultaneously be boosting norepinephrine in a as a side effect, because there is some overlap between the transporters that try to pull dopamine and norepinephrine back. The dopamine transporter, norepinephrine transporter, so you may end up with some symptoms of stimulation of alpha-1, heart rate goes up, you may have change to heart, to blood pressure. When folks have Sabina's asking how psychosis treated, and that is difficult because you don't want to drop dopamine too much, and then you end up with essentially Parkinsonian symptoms. So the treatment tends to be, like with any medicine, have them on the least possible dose that they're still getting symptom improvement. You can change to a different treatment approach. Sometimes folks will say treat with a really low dose antipsychotic, and that's enough to manage the symptoms. You'll see Seroquel tends to be the go-to, but a really, really, really low dose. I want to say, and I'm gonna have to look this up because I'm not completely familiar. That there's a medication specifically to address kind of psychotic symptoms in this scenario that Sabine is talking about. I don't know how long that's even been out. I have no prescribing experience with it. So I really don't know. Kind of the way it's been managed historically is you do the best that you can by, like we said, reduce the dose. This wouldn't be a patient who you would manage without consulting somebody who's has managed patients with Parkinson's, who then does have those side effects. And not everybody's going to have it, but you do need to be prepared and, alert patients to the possibility of those side effects there, what to do to call the clinic, and kind of have a backup plan of reducing it, another medication that you could switch to. Because, I don't have any experience prescribing that particular medicine. But I've also not worked in an exclusively, real high percentage geriatric kind of population. So, I tend to see folks who are well too young, well too young to have that. So, I'd love to have a drug rep come give me some more information about it, or go to a program for that particular medicine. Trying to think. So with Parkinson's, kind of the take-home message: awareness of the cognitive symptoms that can precede, the affective symptoms that can precede the motor symptoms, and generally the treatment plan, the treatment approach is replacing the dopamine that has been lost, and side effects, so that you can monitor and educate patients for anticipate what to expect. So not a traditionally psychiatric issue, but there can be depression and things that look a lot like depression, or potentially cognitive problems. There's dementia associated with this. Presence of Lewy bodies I think where it's eventually going to end up is that dementia for folks with Parkinson's is going to be Lewy body dementia. Two more of these fine folks that we'll talk about. Phyllis, postmenopausal, and those are her vitals right there. So with someone being postmenopausal, there may be some labs in particular that you would want to get for this gal if she comes in presenting with any of these things. So those vitals aren't things that you would manage, but you would certainly be concerned if you saw them and those lab values. But any additional labs you might want to get, say she's meeting criteria for depression. Sure, perfect. Yeah, A1C, well, we wouldn't expect that to be great. Certainly looking, her BMI is elevated, her total cholesterol. You want total cholesterol under 200. So the medications that you would certainly stay. Oh, sure. Mm-hmm. Postmenopausal, depending on if she's on any sort of needs or is on any kind of hormone replacement therapy, ANCC is not, and we're certainly not going to ask you about estrogen levels or testing or levels of luteinizing hormone or not necessarily with Phyllis, but those hormones that are real specific to psychiatry that you will be sure you want to know is, of course, PSH, free T4 levels. You want to know normal labs. What's normal blood pressure? What's healthy blood pressure? Healthy cholesterol, healthy glucose, like we talked about at the on-site. And you'd mentioned, like Sabina, you had mentioned vitamin D3, you mentioned TSH, B12 and folate. Avoiding medicines that have a propensity to increase blood sugar, contribute to hyperlipidemia. So you think atypical antipsychotics, or at least most of them, the ones who are not more weight neutral, that would be not your first choice. Paxil, mirtazapine, not your first choice. So you may see, not a lot, but you may see questions that require you to essentially translate lab values given and then make a treatment decision based on that. Or they'll ask you, drugs with a certain side effect profile that you would pick based on that. So it's really an application issue. So, but yeah, like I said, go back and refresh yourself on normal potassium, calcium, sodium. And someone had asked, is there a standard ANCC lab set, standard reference ranges? If you go out and buy an ANCC book, because they make their own study guides for the exam. They're just really brief and are not sufficient on its own for you to study for boards. They may have that, but if a question requires your knowledge of labs to make the right application, it's going to be pretty obvious what is within the normal range and what is not. I think an example I'd given was a lithium level of, like we said, 1.8 versus, it's 1.2, right on the cutoff, or a Depakote level that's right on the cutoff of low. So if you know the normal range, you will be able to recognize, that is significantly out of the range. Like an H&H of, sure, especially for a man. That's pretty low. So yeah, an H&H that is obviously out of range. I think for men, H&H is, I'm kind of guessing here, sort of pulling from old times, somewhere around 17, 18, and somewhere around 50-ish. They wouldn't do, 16 and 49. It'll be, whoa, or a lab value that shouldn't be there at all. A troponin is a good example. That should never be, under the best of circumstances, that shouldn't be elevated. So Phyllis, rememorize normal labs, because it would be rough to miss a question that you would have applied appropriately just with having that information. GFR, big one, relevant for our purposes. Lipids, triglycerides, LDL cholesterol, HDL cholesterol. And last but not least, Justin, 41, type 2 diabetes, peripheral neuropathy. For the past 2 months, endorsing these kinds of symptoms. So the go-to medicines for mania are Rob has a question. Yeah, I think that one, the lithium for that question, I think we may have mentioned it earlier, was a lithium level of 1.8, but that would be for someone who's in a hospital and you're monitoring labs pretty closely. That would have been caught before it got that high, because that's a pretty high intentional lithium level. And then one Depakote was really low, and one Depakote was on the higher end of normal, which is really what you would expect to see for someone who's getting really close monitoring of inpatient, up titration. But you're right that lithium, hey, this guy has mania. You might see lithium on his list. So it's really an issue of, again, recognizing those levels, which would be a relevant conversation to have with this guy, because he's irritable, he has type 2 diabetes, not sleeping, arguing, speeding. So therein lies the question for this guy, knowing what the go-tos for, and like we talked about in that module, you have maintenance of bipolar 1 disorder, and then you have acute management of bipolar 1 disorder. So for this guy, that this is more of a, if he's not on anything, this becomes an acute management. What might you pick? What might your first choice be? He needs some sort of mood stabilization. Any thoughts? And you don't have to pick a dose, I mean, unless you want to. But you could say all other systems, let's say his blood pressure's fine. Let's say at this point his kidneys are fine, but you would be concerned considering he has diabetes. Any thoughts? If you had a patient who came in and they were manic and they had type 2 diabetes, what would your first choice be? Or a choice? Ziprasidone. Going in the atypical antipsychotic. Depakote. Why maybe Depakote, Kelly? I like it. How does that fit this guy? It'll work pretty quick. Yeah, Cecilia. And it'll leave his kidneys alone. Sure. Because, and that's a higher, that's kind of the big picture here, is somebody who you would be concerned about things that are going to leave his kidneys alone considering the existing stressor. And you know, Depakote is associated with weight gain, but something I'm going to have to research is how really is the mechanism on which, because there's a lot of different acetylcholine receptors and some adrenergic receptors that all these other antipsychotics like Seroquel and Zyprexa, who block alpha-1 and they block muscarinic acetylcholine receptors, and that changes sugar metabolism, that changes how your pancreas responds to signals to release insulin or not release insulin. So with this case, and that's really the point, is the A1C, the blood sugar. Well, that is really the issue with atypicals that you want to consider. Does that drug side effect profile match this patient's other issues that they have going on? If he's already really overweight, if he has difficulty managing blood sugar anyway, you know, his processing of blood sugar is disturbed already. So if you have a chance to prescribe something that is more neutral to that, to how it affects blood sugars and cholesterol and triglyceride, then pick that. I think Depakote's sure. Acute management, you can maintain it with monitoring. Sure. Benzos are often used for acute kind of sedation management of folks with mania, but in conjunction with indications, actual indicated medications, a mood stabilizer, and antipsychotic. So there are more weight neutral antipsychotics, more weight neutral. Ziprasidone tends to be one of them. Lurazidone, one of the newer ones, Latuda, also one. If this was a management issue, Lamictal would probably be a great choice. But Lamictal isn't something that you can start somebody on if this is their presentation. And then to complicate the picture, let's say he's trying to manage this with alcohol. Think about the labs that you're going to get maybe before you would start at Depakote. 6 to 8 beers a night. It's not a huge amount, but that's well beyond healthy drinking limits. This may or may not be enough. Right. This may or may not be enough to have impacted his ALT, AST levels, but you would have to check. So again, this is just another facet to this guy's case. If he were just a 41-year-old with mania, with symptoms of mania, you could say, oh, well, I would do Depakote or I do atypical. But then you add a layer of a medical issue, and that may change. And then you may have to change again, depending on what liver function test shows. But the practice is that even if someone's, if you have another option to Depakote, you should probably pick it. But Depakote can elevate liver enzymes, and it doesn't mean you discontinue it. You may cut back, you may monitor, because even starting Depakote can cause an acute, kind of a short-term bump in liver enzymes, meaning essentially a temporary damage that the person adjusts to, probably because they improve their ability to process it. And then the liver enzymes will return to normal. But you got to check first. So you'll have in your mind medications that require certain monitoring. You want to revisit what are signs and symptoms of hepatic injury. What are signs and symptoms of, renal insufficiency? What medications do I want to avoid or pursue based on metabolic or hepatic or renal or cardiac kinds of function, blood pressure? Does the person is this an elderly patient who has a cardiac, do they have a dysrhythmia already? Think which of the SSRIs or TCAs you'd want to be sure to stay away from. Right, and that's just the reality of it, is you have your first choice based on symptoms and peripheral kind of factors, other conditions, other medications. But sometimes you just have to do it anyway. And you monitor more closely and you keep the lowest possible dose. Maybe for this guy, his liver enzymes, they were on the higher end of normal, but Depakote was the best choice. Maybe he's allergic to atypicals. Maybe he has. I worked with a guy who essentially had an allergy to atypical antipsychotics, that his akathisia was so significant he couldn't tolerate them at all. But if you know what you're looking for and the labs you're looking for, we have our atypical standard, the standard monitoring that you do for folks on atypical antipsychotics about the metabolic kinds of things, your sugar, your lipids, triglycerides, weight, the schedule for that. So a lot of this material is really patho and assessment focused. You will need to be familiar with that for comps here and for boards, but not for a ton of your boards. Only about a third of that exam is going to require you to really be clinically, have good knowledge of clinical concepts and applications. But it's a third of the test. So next week, we're kind of continuing this medical focus exam board preparation. We're going to talk about the intersection of reproductive medicine, reproductive issues, and psychiatric medications. Because people's depression and anxiety doesn't go away just because they get pregnant, such and such. Certain disorders associated with the menstrual cycle for women, post-pregnancy, baby blues versus postpartum depression, distinguishing those. And metabolic, more on metabolic because that's a big assessment prevention kind of topic. And Dr. Fogger's saying that, yeah, lithium is a drug that's often tested on. So drugs that we've covered, that there's a level that you would check for. So that's yeah, just want to be sure we hit everything. Kind of jotting notes for as you're studying. Cardiac labs, not cardiac monitoring, but to be able to recognize this presentation, this person is having blood pressure is out of control. Cardiovascular risk factors, they're on medications, and even you will have to be somewhat familiar with medications that are not psychiatric at all, like at least in name of them. If a person is on glipizide, for example, we had that question on this most recent exam. Things that I'm sure y'all will be fine for: beta blockers, statins, drugs that we don't write but need to be familiar with. So cardiac function, endocrine, think about those diabetes medications, signs and symptoms of renal insufficiency, prevention, immunization. I mean, technically they could ask you when, pediatric immunizations if they really wanted to. I wouldn't focus a lot on that. I would focus more on the secondary prevention end of things with the screenings for breast cancer, colon cancer, metabolic syndrome, those kinds of things. Any last minute questions till we continue our kind of patho for next week? Because again, not much new stuff the rest of the way. It's mainly going to be focused on comp prep, exam prep, revisiting first year things, leadership, research, professional, transition to practice kinds of things. Ethics and systems. Changing policy. The process of identifying a practice issue that could be improved. PICO questions. Which is good. We're just going to be focusing on reviewing from here on out. So, all right, everybody, I'm going to go ahead and stop the recording, and please feel free to email us with any kinds of questions. An exit exam pretest. Exit exam pretest. Huh. Not something that I had considered. We can contemplate that, but let me not say yay or nay. That's kind of what I'm getting, is that it would be sort of a practice exam. Sample. Well, the purpose of that is, or what we want to do to achieve that essentially is to start. We really want we required a board vitals membership just to kind of last you through August, pretty much, and we're going to be assigning kind of content periodically, so that with the goal of it paralleling what we're talking about in here, to really kind of concentrate the review topics. So you will see as you go through the Board Vitals product, it'll let you know areas that maybe you're not as strong in, and you can concentrate just on those kinds of questions. So yes, along the way there will be that. We're going to do that, yes. Okay. Well, hope y'all have a good evening.